Good morning, everybody. Welcome to our integration project. We are the team 42, which is formed by me, Daniela Genedia Córdoba, Noemi Martínez Munguía, Kristen Said Seide Facuja, and René Vélez Torres. Our consultant was the teacher of English medical class, Misael Vladimir Romero Garcia. We are currently in our third semester at the Durango Santander University, in the city of Hermosillo, Sonora, in medicine school. Without further, let's get started talking about liver cirrhosis.
What is cirrhosis? Well, this is a disease in which healthy liver tissue is replaced by scar tissue that, over time, prevents the liver from working properly. Alcohol-induced cirrhosis, also known as alcohol cirrhosis, is the term used to describe cirrhosis that has been caused by drinking excessive amounts of alcohol, usually over many years. Some symptoms of cirrhosis occur because the liver is unable to prevent the blood breakdown process, produce clotting proteins, and help with the absorption of fats and fat-soluble vitamins. The cirrhosis symptoms include decreased appetite, nosebleeds, jaundice, so yellow discoloration, small spider-shaped veins underneath the skin, weight loss, anorexia, itchy skin, and weakness. More severe symptoms include confusion, difficulty, abdominal swelling, etc.
Talking about physiopultological aspects, liver cirrhosis is a final stage of the all progressive chronic liver diseases. As a consequence, there are fewer liver cells, and therefore the liver stops performing its usual functions, among which is the synthesis of the proteins, especially those that act in the blood coagulation, the production of bile, the neutralization and elimination of substances foreign to the organism, and the production of the defenses against infection. The normal circulation of the blood through the liver is also impeded, producing what is called portal hypertension. Where there is portal hypertension, blood accumulates in the territory of the portal vein, producing an increase of the size on the spleen, which increases its usual function and destroying red blood cells, as white blood cells and platelets. While on the other hand, the accumulated blood seeks different paths, and the esophageal varices can form, which can rupture and lead to hemorrhage, and they usually sever.
For diagnosis, the gold standard is a liver biopsy, taking a tiny sample of the liver tissue examined under a microscope. Common lab findings include elevated serum bilirubin as well as elevated enzymes like aspartate, aminotransferase, ALT. Here AST is usually more elevated than ALT, alkaline phosphatase, ALP, and gamma-glutamyl transpeptidase, or GGT, can also be elevated, and thrombocytopenia or low platelet count. As a treatment, generally the scarring in cirrhosis is irreversible. So first of all, it is important to prevent continued liver damage by identifying the underlying cause and treating that. For example, stopping alcohol consumption or antiviral treatment for those with hepatitis C.
Clinical case of a 41-year-old female patient with no known personal pathological or surgical history who came to the hospital with a 3-month history of general weakness, asthenia, adenamia, and unquantified weight loss. All this associated with 1 week course characterized by unquantified fever without wholly predominance with increased abdominal perimeter, pain in the right hypochondrium, and jaundice in the skin, lips, and sclerotic eyes. Physical examination revealed a distinct abdomen with the presence of fluid in the peritoneal cavity, mild pain of deep palpation, coronal tympanic seen, changeable dome seen, and positive wave seen. No masses or visceromegally palpable. No other significant findings on physical examination. Different imaging studies were performed. The endoscopy didn't show esophageal varices in the stomach. The mucosa was observed with a mosaic pattern, with erythema and edematous folds. Erosions were observed at the atrium level. In the duodenum, erythema and erosions were observed in the bulb. In the tomography, the liver presents disease of the right hepatic lobe, observing compensatory hypertrophy of the left lobe. The parenchyma is heterogeneous micronodular with lobular borders without observing solid focal lesions or cysts. There is no extrahepatic dilatation, visualization of intra-abdominal fluid at the perihepatic level, right parietolic slide and pelvic excavation. On ultrasound, liver disease in size, irregular boards, and coarse heterogeneous texture with multiple macronodular images in its parenchyma, intra and extrahepatic duct of normal caliber. Surgical abscess of the gallbladder, pancreas diameter, and heterogeneity per cell. The spleen is enlarged without focal lesions. There is an abundant free fluid in all abdominal recesses. Some diagnoses such as hepatitis B or C were suspected, as well as neoplasia and liver cirrhosis. The patient presents a very similar picture to already known hepatitis B. However, she did not present some manifestation described in this one, such as splenomegaly and cervical lymphadenopathy. In addition, the patients had no history of any form of exposure to the virus, so it was ruled out. Within the differential diagnosis of this pathology, a test of antibodies against the hepatitis C virus was ordered and was negative. This test is essential for the diagnosis of hepatitis C, which is why the diagnostic was rolled out. Although the patients in our case present a picture of jaundice in skin and mucosa, the pathology of obstructive jaundice was ruled out since the patient did not show other symptoms related to the pathology, and thus we left only one option. We observed elevated direct and indirect bilirubin, bilirubinuria, elevated alkane, phosphatase, aspirate aminotransferase, alanine aminotransferase, radio greater than 2, decreased albumin and prolonged protopic time suggesting liver cirrhosis. In addition to these findings, the ascites fluids analysis confirmed the diagnosis as it shows a leukocyte count of 2,000 and phylonuclear leukocytes of 47, but decreased, which further supports our subscription. An ultrasound was also performed, confirming the diagnostics by obtaining topographic findings compatible with liver cirrhosis and the presence of ascites fluid. In this way, the case is complete, being the diagnostics of liver cirrhosis due this alcohol intake for several years.
To prevent cirrhosis, if you have a liver disease, you should avoid alcohol and maintain a healthy diet. Choose a plant-based diet with plenty of fruits and vegetables. Select whole grains and lean protein sources. And you reduce the amount of fat and fried foods. Maintain a healthy weight because an excessive amount of fat in your body can damage your stomach and reduce the risk of hepatitis. Sharing needles and having unprotected sexual intercourse can increase the risk of hepatitis B and C. You should ask your doctor about hepatitis vaccines. In conclusion, Liver cirrhosis is the final consequence of any disease that processes chronic inflammation of the liver. This disease is more common in males. The dominant etiology is alcohol consumption. The main complications are esophageal varices, ascites, and hepatic encephalopathy. Digestive bleeding is the main reason for hospitalization, and most cases arrive in advanced stages of the disease, and Child-Pugh stage 8 predominates. The most common infections are urinary tract infections, pneumonia, and SVP.
Well, as bibliography, we use internet pages such as PubMed, NHS, Cielo, Academic, Google, among other scientific medical bases, and we take a cut of point articles with scientific relevance. Thank you for attention.